communities so that we can reach out and service more remote and underserved populations, but also balance in terms of patients' location of care. We're looking for people in independent living situations, but also in assisted living and long-term care. But balance, I guess, is the word I keep coming back to. Also disease mix. The healthy hospice has a healthy disease mix, and so we're trying to provide services to all across the continuum of those different hospice metrics, I guess. And having an experienced staff and a stellar on-call crew makes it possible. Our service area is the largest service area of any hospice in our community. We service patients from Fort Collins all the way down to Castle Rock.
Wow. The whole Front Range.
The whole Front Range, yeah. And so it's kind of a robust business plan, but we're a fast-growing hospice, and I think our community is telling us that they like what we're doing.
That's wonderful. Right. So I think there may be some confusion about really what hospice care is and what palliative care is and how they're different. So I'd like for us to just explore that whole realm a little bit today, and we'll talk about hospice, but then really hone in on palliative care. And let's talk about how palliative care services in particular can be helpful to a busy primary care practice. So hospice care, let's start with that. Give us the basics. Really, what's the definition of hospice care? Who can benefit from it? How does it all work?
All right. Hospice care, first, it's end-of-life care for patients who are no longer pursuing curative treatments. So if you have a prognosis of 6 months or less, probable prognosis of 6 months or less.
Because that can change.
That can change. Yeah. There are patients on program longer than that and shorter than that. And you have, no longer are interested in pursuing curative or aggressive treatment, and you're eligible for hospice. But it's not how would I say, it's not necessarily limiting. I don't want to make it sound like when you come on to hospice that it's a prison sentence, that you can't change your mind. One of the things that I tell patients when we're admitting them, which I do some, is that it's not a decision that you can't change tomorrow. So it can flow back and forth.
Yeah.
And there are a number of patients who are discharged alive from hospice. But if someone does meet that prognostic kind of criteria and they need help and care in the home, hospice provides a wide array of services.
And how's it determined whether they meet that criteria?
Well, the fiscal intermediary sets guidelines for a person's level of debility to make them eligible for hospice along a continuum of 7 or 8 different kinds of diagnoses.
Okay.
So if a person is meeting eligibility and has that their physician's certification statement and are wanting hospice, hospice can come in and provide services that include pharmacy, DME, nursing, spiritual care. In our program, we also offer touch therapy, massage therapy, pet therapy, a lot of the nicer therapies.
Yeah.
But the way hospice works from a fiscal standpoint is that a lot like a managed care organization, you're paid the same amount of money for each patient that's in your program, and your job is to manage the care of this total group of patients. So sometimes patients need procedures that are expensive and sometimes they don't, and the well-managed hospice has the ability to provide those things like TPN if necessary or radiation for palliative purposes, and still have the whole work well. So we're not a restrictive hospice. Patients can get services that their interdisciplinary team thinks they need without necessarily having cost be a barrier.
That's really great. You mentioned healthy hospice. Is that what that means?
That's what I think it means. Is that what that term means?
Yeah.
Healthy hospice is a dynamic hospice that has all the balances that I was talking about. Other hospices might have a focus on long-term care, for instance, and in those cases, their population tends to be more geriatric,
Yeah.
and there's some balance that's lost in that.
Okay, so great. I think we have a pretty good idea about hospice. So then let's talk about the palliative care model. What is palliative care? How does it relate to hospice care? How is it different?
Well, palliative care is it's a complicated word that not everyone understands the same way.
I'm not sure I understand it. So.
It basically stands for comfort care
Mm-hmm.
or symptom management. And a patient can receive palliative care while they are still pursuing curative treatment. So it's not like hospice in that you have to have given up curative treatment.
Mm-hmm.
You can receive palliative care in conjunction with curative care.
Yeah.
I believe most physicians, almost every physician I know, provides palliative care to their patients. They are providing symptom management along with their treatment of the condition, whatever it might be.
Mm-hmm.
But over the last decade or so, a specialty has formed around the issue or the area of care called palliative care.
Mm-hmm.
And it's been primarily a physician kind of model. There are boarded palliative care physicians.
Right.
It's a specialty area.
Yeah.
And their interest is in how to take care of a patient who has symptoms that are exacerbated.
Mm-hmm.
But palliative care in that model isn't necessarily what's being followed across the board in the community.
Right.
So in our case, for instance, we have a two-pronged approach to palliative care.
Mm-hmm.
One does include the symptom management or comfort care.
Right.
But in addition to that, we provide kind of a case management approach for patients who are in transition.
Right.
And transition can mean from hospital to home or nursing home to home or any kind of transition from one location to another, but also the transitions that are related to their disease process. So they're getting sicker.
Yeah.
And so in our model, we have a case management approach that tries to pay attention to those changes and bring in necessary resources to help that transition so that it doesn't result in a panic and a rehospitalization, for one, as a primary goal, but also to bring reassurance to people during these transitions that they have someone who is supporting them. And this is one way our version of palliative care, which we call transitional care, can work well with primary care, especially in practices where it's difficult to see patients, difficult to have them make their appointments.
Frequently
get in to see and have the symptoms managed. If a physician were interested in our program, we would have a nurse practitioner be available to go out to where the patient lives and report back on symptoms and collaborate on appropriate interventions.
Yeah.
So it can be a wonderful extension of a physician practice.
Exactly. Marvelous. So it's much more, really, than just traditional medical care.
It's way more than traditional medical care. In my mind, traditional medical care resembles silos of care.
Yeah.
And each one is based on a law that was written without consideration of the other silos necessarily. And so what we came up with was an idea that would cut across the silos and provide people support as they were transitioning in and out of any one of them. Sort of the glue that kept things on the straight and narrow.
Yeah, yeah.
So, and it's been pretty successful. You know, we have a good track record of being there for people as they go through change and preventing rehospitalizations.
Wonderful. Which is good for keeping costs low as well.
That's the whole point behind it. There's a huge initiative in our country under Medicare reform about saving the costs of repeated hospital admissions, readmissions. Our program was conceived to kind of address that with hospitals.
Yeah.
And that's primarily who we work with. I think there's also room for physicians in their role post-discharge to augment their practice by maybe collaborating with the palliative care program and making sure that their patients are seen. A patient not being seen in the first 30 days post-discharge by their primary care physician correlates 50% to readmission.
No kidding. 50%. So it's really important to get that follow-up from the primary care.
Yeah, to address medication compliance, to address how well were you instructed by hospital discharge. Do you understand how to best care for yourself? Maybe even to explain symptoms and what's going on from a physiological standpoint so that patients don't panic when they're having a normal reaction.
Right.
So education too.
Yeah.
All of those things are what palliative care and transitional care can help a physician practice achieve for their patients that are discharged post-acute.
Really good to know that that resource is available to the practices. Let's talk about this idea of patient-centered care for a little bit, because you hear that term a lot, and I think people interpret that very differently or use it very differently. What does it mean to you in palliative care?
In palliative care, it means the same thing that I think it ought to mean in any kind of care. I don't think patient-centeredness changes when it's palliative or hospice or hospital or physician.
Or regular primary care.
Regular, yeah. It's all about listening to the story that a patient has to say. And there's one kind of illustration of this, I guess, that it's a difficult one for some people to imagine, but believe it or not, in hospice, in my experience, not everyone has wanted comfort care. Many of us associate hospice with comfort care, but patient-centeredness would listen to the patient's goal of care and not impose a bias.
Not impose the practitioner's own bias.
Correct. And it's really hard to adjust what you think ought to occur.
It's got to be, because you have your own ideas about how things should go and if you could run the patient's life.
Yes.
This is what they should do.
Yeah, exactly. Yep.
So let's talk about this whole interdisciplinary team approach. This is your graphic that you have created. Explain what's going on here and what all these dynamics are.
Well, it's a circular sort of intertwined approach to decision-making on a patient's behalf that kind of offers an option to more traditional silo approaches. The idea would be that every individual involved in the care of the patient interact as a team rather than as separate islands.
Yeah.
Like the Department of Social Work or the physician has a practice that's separate and outside and not part of the whole, or even CNAs who have things that they observe that are really pertinent to the care plan.
Yeah.
Need to be brought in to
and listened to.
Yeah. To the conversation about how are we going to help this patient realize their goals. And so in our practice, in our hospice and in our palliative care program, we try to knock away or cut through, just like the transitional care does in the larger healthcare continuum. We try to do that same thing within our program so that everyone is integrated in the care of the patient. Patient's in the center.
The patient and the family in the center, yeah.
And everyone around is focused inward versus a model where sometimes departments acting as islands can have a misunderstanding of a patient goal, and they can go off in a misdirection for quite some time without being lassoed in because they're not interacting as a team and being reminded of, no, wait, that's not what they said.
Yeah.
So this model is actually a model that is alluded to, not quite mandated, in the regulation that governs hospice from Medicare, CMS, and we just have taken it to heart and let it become part of our organizational structure. So our whole organization operates in this same manner.
And we talked a little bit already about the traditional model versus your case management model.
One of the misconceptions or the barriers to palliative care is the understanding of it as primarily a physician-based model, medical model. And so we're trying to convince people about how our transitional care can benefit their practice or their assisted living home or wherever it might be.
Right.
One of the responses is that you're talking about a doctor's visit once a month, and you're looking for economies in facilities where there are many patients. And in truth, our model is only partially physician-based, but the other elements of care, as you can see in the slide, spiritual counselor and a case management approach. We actually have a care coordinator who makes proactive telephone calls to patients who are judged to be at risk. And so it's much, much more. And so the use of the word palliative creates an image in some people's mind that you're talking exclusively about a physician-based approach to a problem, and ours is not that design, and that's why we more like to use the word transitional in conjunction with our palliative care to communicate that it's more than.
So are you using that term, traditional care?
Transitional care.
Transitional care versus...
More and more, especially in times like this where I'm describing our program. Palliative care to us is transitional care, and I just want to make a point about the two elements. Yes, it is symptom management, but it also is walking hand in hand with people through these changes.
Yeah, a much more holistic approach.
Much more holistic approach, yeah.
So we all know that the caregivers and family members of patients who are going through really difficult chronic medical situations or end-of-life issues really need support too. Talk a little bit about what the kind of support you provide for family members.
Well, one of the leading causes of hospital readmission is primary care breakdown or panic, or however you want to describe it. And so caring for the family has to go hand in hand with caring for the patient.
So the family know what to expect.
Education of the family, support of the family. You know, how does the primary care physician want us to communicate to the family the nuances of this disease process? So there's no way that you can separate them. In hospice and in palliative care, our approach is to care for the entire environment of care.
Right.
And that includes the dog.
The dog.
If need be.
That's great. You don't often think about the importance of the family. You know, people really do consider their pets part of the family. And
yeah, you'd be surprised who people hold on to during these stages of life.
Yeah.
And the idea is to be open-minded to that. Everyone has their own definition of what family is.
Yeah. And so for you to just be open and aware of
listening,
listening to what's important to the individual. Yeah. So the big question is, who pays for palliative care? Does CMS cover that as well?
Well, different companies' approaches to palliative care are funded differently.
Okay.
Some people construe their palliative care as a component of home health, let's say.
Okay.
And they're looking for ways to have their patient base be eligible for home health, and then the visits and such by the nurse are covered through home health.
Because your services are primarily delivered in the home, correct?
In the home, correct, yeah.
Sometimes in the hospital?
Anywhere, really.
Yeah.
If someone will have us, we'll go. We don't have a barrier. Someone else might have a barrier, but we don't have one.
Yeah.
Other palliative care or transitional care programs like ours, funded by traditional physician reimbursement mechanisms like CMS, Medicare, but also Medicaid and commercial insurance payers. There are some palliative care programs in our state that are grant funded as well.
Oh, really?
I think that I can think of at least two right now off the top of my head who have received grant monies. The grant monies are largely intended to test ideas on how to prevent hospital readmission. So there's money available now for different programs and ideas to prevent that from happening and saving Medicare money. And so it's traditional insurance from a home health standpoint, but also from a physician practice and then grant funding. But it is difficult for palliative care or transitional care to find economic balance. Part of it is it's cutting edge. It's not having patients come to a location.
Right.
It's going out to where patients are. And there's a big movement, I guess, and maybe this is old news, but more and more physicians are doing home visits.
Right.
And so palliative care, transitional care, in our version anyway, is right in sync with that trend. We just have to figure out how to make it all work out financially.
Yeah. So generally there is funding available, there is money available for people who need the services. They are able to get it reimbursed.
There is, and in our case, we have a foundation that's a sister organization that is available to provide funds for situations not covered by traditional funding sources. Sometimes families need respite care, and there are not a lot, but some resources available for that.
Yeah. So are most palliative care patients seniors?
I would say yes, only because most patients in general are seniors. They're the higher users of health care. But palliative care is not necessarily, by definition, for seniors. It's symptom management for people who have symptoms that are out of control.
So younger people also who have chronic diseases or other medical problems that need management.
The majority of our patients at this point in time are not seniors.
Really?
That's true. It's because of hospital relationships and that we are being utilized by oncology for
so you
post-discharge
have a lot of cancer patients.
Correct.
Yeah. Correct. And as you said, people can move in and out of the care models as well.
Yes, they can.
Yeah.
The care models are not prohibitive to patient choice.
Yeah.
So that's the thing about being patient-centered is it's your ball game, and we're the visitors, I guess, or whatever, however you want to put it. But it's not a prison. You can go in and out if you want to.
Yeah. So let's talk about one of our big goals in the Colorado MESA initiative is to help primary care practices be more efficient with their time. So how can a busy primary care practice lean on your company or a company like yours to alleviate some burden on the practice?
Well, the clearest example of how a palliative care or a transitional care program can augment private practice would be as an extension of the practice to the patient's home. So if your practice doesn't permit you the time to do home visits, you don't have the staff to do home visits, yet you are aware of that you have a significant number of patients who are post-acute discharge, our program would be an excellent one for you to utilize as an outreach to those patients. You could call us up. We would go see the patient. We would collaborate with the physician and intervene if symptoms were manifesting and more or less take the burden off of primary care and also prevent rehospitalization. So I believe it's an excellent way for a private practice to embellish their program, make it richer for their patients.
Yeah, yeah. And that's just good patient care.
Just good patient care.
Absolutely. It's a win for everyone. And so some doctors might be concerned about handing over their patients, if you will. How do you keep them in the loop and keep them involved?
Well, in our program, we consider them to be the driver still. We are acting on their behalf, and we collaborate, we communicate. We don't change orders without their consent. So they're really still in the driver's seat. It's not that they're giving up a patient to another practice. It's an augmentation of their practice. It's making their practice richer.
Wonderful. So everybody should be able to take advantage of that.
I think so.
How would does a practice access your services? How do they find someone in their community to work with?
Well, I said earlier, our service area is quite broad.
Yeah, you're all over the Front Range.
We're all over the Front Range. So,
but we've got folks in all corners of our great state of Colorado in our program here. So if somebody's on the western slope or down in Pueblo,
I would say a great access point would be the local hospice provider. Just recently, in the last 5 or 6 years, the Colorado Hospice Organization has merged with the Colorado Palliative Care Organization into one organization called the Colorado Hospice and Palliative Care Organization. And so that's a statewide organization. It's a nonprofit that could also be a good access point for where can we get palliative care or transitional care services in any of the communities in Colorado.
Okay, good to know. And I assume they have a website.
They have a website, yeah.
Yeah, and we'll get that. We'll find that resource and put it on the on our page with this archived webinar for you. So as we did talk about a little bit ago, some patients get better. They no longer need primary or palliative care and can kind of go back to their primary care physician primarily. Talk a little more about those phases and what's, I'm sure there's not a typical, but what do you tend to see with people? What's the progression of care?
Well, there's categories of care. Our organization is trying to reach out towards a more chronic population with not necessarily end of life. So in those cases, we would kind of follow the same pattern that we do in hospice, where there are patients' stated goals and there are goals that they work through with their physician. And when those goals are achieved, or when issues are resolved or resources brought in, and there is no longer a need for us to be seeing them, they are discharged from the program. And then at any point in time, they can be re-engaged.
They can come back in.
And so it really has to do with the flex in a patient's path or story. You know, they're going through ups and downs, and when the downs are there, I think we're there. And that's what I'd like for folks to realize, is that it can be intermittent and it can be aligned with need. It doesn't have to be, it's not according to, like hospice, a certain criteria or of eligibility. It's essentially the physician's or the patient's assessment that they need help.
Which is really what leads me into the next question. I think there could be a stigma, right, around the idea of this, and that really it could be signaling the beginning of the end. And how do you talk to people about that? How do you help them understand that that's not necessarily the case, and you're really here to help them feel better and improve the quality of their life?
Well, this is one of the problems with palliative care being so associated with hospice.
Yeah.
A lot of people have a fear of the H word.
Yeah.
And palliative care, like I said earlier, is essentially symptom management. And a person doesn't have to be in the end of their life to need symptom management. And palliative care for us is also managing transitions, and transitions can occur at any stage in life. So I would say to separate palliative care from end-of-life care and talk about it in terms of just bringing comfort to the patient for whatever they're going through, whatever their issues are, is a great way to remove the stigma. It doesn't have to be associated. But at the same time, palliative care is a great format for early discussions to occur with patients who are in the last years of life, to learn about what it is that they're facing. And a lot of the fear can be taken care of during those preliminary points of contact.
Just by talking about it.
Just by talking, yeah. It's
Yeah.
a reassuring kind of program that dispels a lot of myths about end of life, and it can bring peace and comfort even at the palliative care stage for a patient who probably knows at some point soon hospice is going to be appropriate. So in that way, palliative care does blend nicely with hospice, but it doesn't have to. And if you're really listening to the story, you'll know whether or not that's on the agenda, and you'll know whether or not it's something to talk about.
Yeah. Wonderful. Thank you. So let's just check in and see here if anyone's got any questions. I don't see any right at the moment, but if you've got anything you'd like to ask Rob, please go ahead and type it into your control panel. And I'll just go through a few housekeeping items here, and we'll give folks a chance to put their questions in if they'd like to ask anything. I want to remind everybody that we've got a lot of great stuff for you on the Colorado Mesa website. So go on over to coloradomesa.org and sign in, and you've got access to our webinar archives and handouts, our training videos, our discussion forum. If there are any questions that you have about today's webinar that you don't have answered, feel free to post them on the forum, and we'll follow up on those for you. Our next webinar will be on the first Friday of September. Can we believe it's September already?
No.
And that's a late one in the month. It's Friday, September 7th. Dr. Greg Gom, who is not able to be with us today, is going to be talking about diagnosing and treating UTIs, which he calls his pet peeves. Pun absolutely intended, he says. He's quite a character, so I think it'll be an entertaining session with Dr. Gom. So I don't see any questions here for you today. I'd like to thank you for being our guest.
Thanks for having me.
It was a lot of great information, and thanks to everyone for participating. Have a great weekend.